Hello again and good evening. Welcome back to the next session. It's about role of open source digital health building blocks on data quality and e-governance in community medicine. This presentation will be delivered by Dr. Pankaj Gupta, Head of Department Digital Health, Access Health International, New Delhi. Dr. Gupta has been working from past 2 decades in healthcare and pharma technology business and process standardization. His previous roles include health tech leadership for US, Canada, and Asia. Now he's consultant at board level of healthcare funds, developing healthcare organizations, and his specialties include healthcare IT, concern, Vista, HIMSS, and data quality. Over to you, Dr. Pankaj. Thank you.
The topic for today is role of open source digital health building blocks in data quality, e-governance, in community medicine. So I'm going to sort of talk about all these key words a little by little. I'm Dr. Pankaj Gupta. I'm the head of the Access Health Digital. We are a not-for-profit think tank headquartered in the US, and in India, we are working very closely with the government as well as the private sector to bring about a lot of change in the digital health. If you look at the standards that have been published, so there is a whole lot of, the National Digital Health Blueprint was published in 2019. The metadata and data standards were published way back in 2014 and then notified in 2018. So, these are beautiful books that have been published. EHR standards were published, the telemedicine guidelines were published. So these are very beautiful books that have been published and, they're lying there on the shelf. Now, are they usable? So, you need these open source building blocks to use them. Basically, what is required is data quality. So, for data quality to happen, you need all these building blocks. These building blocks are something that are derived from the standards. Unless the data quality happens, you are unable to do community medicine, e-governance, epidemiology. So all these things are something which, are not possible to do in case you are, not having the kind of data quality that is really required. So that is an issue that everybody has been facing, that the data quality has been elusive for a very long time. Now, why is it elusive? It is elusive because we wrote these beautiful books, we kept it on the shelf, and we continued the way that we were operating in community medicine, e-governance, epidemiology, and we really didn't pay attention to, how these data could sort of be improved, the data that was being generated from the various systems out there. How could that be improved? And the different systems that were written at different points in time, they were never written up for data interoperability. They were never written up for bringing the data together. They were written up at different points in time in different technologies with little or no standards in place. So that is the legacy that we got, and then over time we've just sort of kept it and we've gone on with it. In terms of community medicine, this is where we are, that, all these different systems are there, which don't talk to each other, and we are unable to bring the data together. So the consolidate the data across vertical programs, states, and private sector is a problem that really has been a problem for all of us. And, we've tried all, I've been working in the system for a long time, and we've tried to sort of make sure that the data comes together from different systems. So my favorite example is that if a woman delivers a low birth weight baby and this woman had had tuberculosis in the past, there is no way that you can connect that the low birth weight was probably because of tuberculosis that the woman had in the past. Because all these systems are in silos, the data is separate, you cannot sort of connect one piece of data with the other. As a result, what happens is that you really can't stitch the story together. So there is no way that you can connect that a low birth weight baby is or could be because of tuberculosis in the past, or the mother having the tuberculosis in the past. So these are issues for which we worked very closely with the government of India. We wrote the Health System for New India book with Niti Aayog. Chapter 5 is a digital health chapter. I'm a co-author of that. In that chapter, we sort of published that for interoperability between all these different systems, you need standardized transactions. So we call it the e-objects. And we need standard data that needs to be carried in those transactions. So the data element need to be standardized, the code sets need to be standardized so that it is machine readable. When one system sends the data to other, it is machine readable. They are able to sort of figure out as to what is the meaning without human intervention. So that is the kind of model that we have been proposing, and we've been working very closely with the government to figure out how that can be institutionalized, adopted across the public and the private sector, across academia. And when I say academia, it is because capacity building is a very important piece. While I'm speaking, I realize that not many people are able to understand everything that I'm saying, because the knowledge base that is required to even understand all this is lacking in the market today. So we have to work very closely with academia to build the knowledge that is required. And we've been doing that very, very closely with a lot of players in the market. On the epidemiology side, we have been failing in the pandemic because the data that is required to come from hospital information systems, clinics, electronic medical records, home care, telemedicine, labs, radiology, pharmacy, and all these different systems that are out there, they need to sort of send the data in standard format. Only then you can analyze it together. Only then you can bring it together and be able to sort of make some sense out of it. Because the data is not available in standard format, somewhere it is coming in paper, somewhere it is coming in Excel sheets. Even if it is Excel sheets, no standardized format in Excel sheets. So, a lot of data scrubbing has to be done, a lot of data cleaning has to be done, and a lot of time goes in that, and data loss also happens. And as a result, we are not able to get the full picture of the patient data. If you don't get the full picture of patient data, the clinical experience is also limited because it's a new disease. For example, the one that we are facing right now, it's a new disease. So clinical experience is limited. Now, clinical experience is going to be based on the data or the patient data that is provided to the clinicians. And the clinicians actually, have to rely on what data comes out with every patient that they treat. So, it enhances their knowledge every time a new patient comes in. And then, the papers are published. When the published papers are in peer-reviewed journals, there is some sanctity to the data that has already been gone through a curation cycle and things like that. Then all the medical fraternity is able to rely on it and able to make decisions. Since we don't have all of that in the short term, because we are racing to contain the pandemic, we are racing to sort of get the epidemiological analysis done, and there is no time for data curation. We need it near real time. So for near real time, the data needs to be in a standard format. It has to be machine readable, and it has to come in a central repository where the entire analysis could be done. So that is something which is completely missing as of now. So, and that is the reason we are not able to identify hotspots, containment zones, and resource optimization on a near real-time basis. We are able to do it, but then there is a time lag, and that time lag is very crucial in times like these when time is of essence, and we really have to sort of make sure that we are able to do this in next cycles of the pandemics. And this one hasn't gone away yet, and this is not the last pandemic that we are facing. So we really need to make changes to the way we are dealing with data and standardized data. In terms of e-governance, the foundation of the resource optimization is e-governance. That's what we say. And in terms of supply chain, beds, devices, durables, drugs, consumables, vaccines, ambulatory resources, human resources, all of them need to be optimized. So, if one district has more or one tehsil has more and the other one has less of the resources, how do you optimize it? How do you sort of say that, okay, move this particular ventilator to the other district because this district probably is not going to become a hotspot? That has to be based on data. That has to be based on registries and identifiers. So standard identifiers. So what are the identifiers we are talking about? We are talking about the beneficiary as an identifier. We're talking about doctors identify as a registry. So we need a doctor's registry. We need a facility registry. So all the facilities that are out there, healthcare facilities, whether it's hospital, clinic, lab, pharmacy, so all need to be sort of identified uniquely, put into registries, and then, all of that need to be brought together. If you have all that, then it's a single source of truth. Then we can do resource optimization. Then we know that so-and-so facility is lacking oxygen. So-and-so facility is lacking drugs. So-and-so facility or so-and-so region, you can do it at facility level, you can do it at region level, you can do it at state level, you can do it at district level. So, you can decide at what level you want to do resource optimization and you'll be able to do it. But you need the single source of truth. And the single source of truth is nothing but identifiers and registries, without which it is just not going to be possible. Today, we are not able to do it because we don't have these registries in this country. We've been talking about it for many, many years, but we haven't been able to do it. And now, when the pandemic has hit us hard, then we are realizing the importance of having the registries and identifiers. Government is trying to do it. It is going to take time, but at the same time, the pandemic is sort of not giving us the flexibility of time, and we need to accelerate our efforts so that we are able to do the resource optimization better. Now, what are these open source building blocks that I was talking about? The one that gives you data quality. So let's look at those one by one. So e-objects for interoperability. So what are these e-objects? So these e-objects are standard transactions and code sets. So standard transactions are any transaction that needs to happen between primary care, secondary care, tertiary care. If the patient has to be sent from primary to secondary, secondary to tertiary, or if there is a claim that needs to be sent from the provider to the payer, then these are standard transactions. So if they're standard transactions, these standard transactions should have a standard format. And not only a format, but also carry the standard code set. So what we said was the e-object was a standard format that we gave for every transaction. So, if there's a telemedicine consult that is happening, we said, at the end of a telemedicine consult, there'll be two things that will come out. One is e-prescription. So there's an e-prescription object. So the e-prescription object is a minimum set of data elements that are required for a prescription object to come out. Then you have the e-referral object. So if the patient has to be referred to, a doctor or a hospital or wherever, to a lab, for example. So, a referral object has to come out, and that referral object is going to carry the minimum set of data elements that are required for the referral. An e-encounter object is going to say that, these are the, in the encounter, what are the clinical notes, what are the diagnosis, what is everything. So, the diagnosis needs to be codified using ICD-10. All the procedures and the order sets given during the consult needs to be having SNOMED as a standard. All the lab, results and everything that come from the lab, they need to be in a LOINC format or a LOINC standard. And any drug prescription that is given, that needs to be in a standard drug index called NFI, National Formulary of India. So these are the kind of standard that National Digital Health Blueprint has published and recommended. And further up, the building blocks that are associated with the National Digital Health Blueprint. I gave you some examples of those building blocks, and the e-object is one of those building blocks. And under e-objects, we have many e-objects. What happens is we have the payer side e-objects and we have the provider side e-objects. The payer side e-objects are the ones where you have the e-claim. So when you have to send the claim in a standard format, so it's an e-claim. And then the payment object, so whether the claim was settled or not, whether it was rejected, or if there is a pre-authorization that is required. So all those, so there are separate objects for each one of those. With the e-claim, you usually will need an e-discharge summary for the inpatient. So on the payer side, they have laid out very standard requirements for an e-discharge summary. And similarly, if there is an outpatient consult that needs to be put into the claim, so then it will have to carry the e-encounter object. So on the provider side, then we have what I've already said: the e-encounter, the e-prescription, e-referral, and the e-discharge objects. What is an e-object? E-object, as I mentioned, it has a header. The header basically tells you, it's like an envelope, right? So when you're sending a letter, and the letter basically has a envelope, and on top of the envelope, it is written that who is sending, so from, and then to whom is it supposed to go. So the header of the e-object is basically that. It's like an to and from. So it gives you the information from where is this e-object coming and to where is it supposed to go. And it carries a couple of other identifiers, unique identifiers for the patient, for the doctor, for the facility, for the beneficiary identification. All the beneficiary details are there and things like that. So it's a header which basically tells you all this single source of truth information. Then you have the clinical brief. The clinical brief will have active allergies, active complaints, comorbidities, diagnosis, and things like that. Then you have prescriptions. So in the prescription, you will have all the lab orders, the clinical orders, and then you have the drug orders. And if a procedure has to be ordered, then the doctor will write the procedure and refer the patient to wherever the procedure needs to be conducted. And then the doctor's advice for admission, that doctor may say, go and get admitted, or there is a follow-up that is required, so come back and show me after so many days or whatever. So that's the kind of structure an e-object has. I just described one e-object for you, but then every e-object has a different structure based on the requirement, but it carries only those minimum data elements that are required to sort of transact between one system and the other for that transaction. The other building block is microservices. So how does microservices come into the picture? So, metadata standards gave out a library of 1,000 data elements and code sets, so 140 code directories. So if you bundle all of those data elements and code directories, you will be able to create microservices. Now, what is microservices? Microservices is the latest technology, is the latest digital technology on which all the digital platforms work. For example, your Netflix, Amazon, all your most of your mobile apps, so they're all built on microservices. So gone are those days when you needed a very large enterprise software to run systems. Now what you need is microservices. They have a very small footprint. The cost of development is small. The cost of maintenance is small. Gone is the time when you needed, very large servers to keep it. Now you can put it hosted on any cloud server, and you don't even need a server actually, because these are serverless technologies. It can sit on your client machine and be able to sort of run very efficiently. So on your mobile platform, so the time for the desktop and laptop is also slowly going away. And we are entering an era where you will have microservices working on mobile platforms and tablets. So nobody will design any application for the desktop and the laptop going forward. It will be designed for the mobile, but it will also work on the desktop and laptop. So you bundle microservices. So every microservice sort of satisfies a functional requirement. Every little small functional requirement is sort of bundled together, and it creates a microservice. And these microservices are bundled together to create modules. And many of these modules are bundled together to create the health delivery information system minimum viable product. So here is a library of microservices that we have already published in open source. So we as in not-for-profit think tank have been working on all of this for a long time. So all the yellow microservices are the ones for which we have published all the specifications, detailed specifications. The green ones are the microservices for which we have already written the code and published in the open source. So it is available on the GitHub that we have, and anybody needs it, they can pick it up, build an application out of it. So gone is the time when you needed to write a lot of code. And now that we are publishing these minimum set of microservices for building a health delivery information system. So if you are required to build a hospital information system, for facility management, you may require add-on modules. But for the core clinical pieces, you will need only these core MVPs, and many of these microservices are now in the open source. So you can just bundle it together, create a user interface on top of it, and you're good to go. So we have put it in the open source, and it is available. Next one on the building blocks is privacy. So data privacy has a huge concern in the market. But in my mind, data privacy is very contextual. So something that is private for one person may not be private for another person. And it is very cultural in nature. So something that is private in one culture may not be considered private in another culture. So it's all, contextual. However, it is important. And from a healthcare perspective, the data of one person can be seen or should be seen only by the concerned physician and not by anybody else in the system. So there needs to be rules and regulations about it. The government is working on putting rules and regulations for data privacy. The bill is pending in the parliament, and it will come out. But for specifically for healthcare, there is an ordinance which has already been done, and which is basically sort of for only for the privacy, the healthcare privacy. Similarly, on the data security side, I divide the data security and the security of IT systems into three parts: network security, data security, and physical security. These are very important aspects. Most of the breaches that happen in healthcare IT systems happen because of data security. And this is what is the fear that so a former US vice president feared the worst, and he underwent a surgery to switch off the Wi-Fi in his pacemaker. The fear is so much that fear of security is so much that he was willing to undergo a major surgery to get this done. And then this fear is not misplaced; it is a real fear, because so there is a possibility, a real possibility. So from a network security perspective, you need the firewalls, you need secure health clouds and IT support systems. From a data security perspective, you need standards, which is ISO 27001 standards, the GDPR standards, and whatever the Indian government comes up with. In physical security, you need physical audit trails, you need ISMS and BS 7799 standards to be in place for physical security. Healthcare identifiers and registries, as I said, the single source of truth. So that's the most important thing. So you need, at the very minimum, what you need is a beneficiary registry. You need a doctor's registry. You need a facility registry for all the healthcare facilities and all that. So what we've done is we've done the design for each one of these registries and we put it in open source. So we said, if a state government has to do it, if a central government has to do it, whoever needs to sort of develop a registry, they should sort of use the same standards, and we've done the design and put it out there in the open source. So we've also done the registry design for the health workers and for the document registry. Document registry is very important because all these documents, every transaction that happens between a healthcare physician or a healthcare clinician and the patient is something that results into a document, and that document needs to be sort of captured somewhere in the registry, and the registry needs to point to the relevant location, because now NDHP proposes a federated architecture that the document can reside in the respective systems, but the document registry should point to the document wherever it is, and you pull it on demand. You don't have to sort of keep everything in a centralized server. And obviously it is not possible for 1.3 billion people. If you were to keep all the transaction history in one server, we really don't have that kind of servers built to date. Nobody in the world has built a system like that will be able to contain or have all the data of 1.3 billion people in one place. So definitely, the document registry becomes a very important piece in the entire model. What is happening now because of all these building blocks is that there is a shift that is coming. There's a market shift towards a Bazaar model. So earlier you had proprietary systems, you had custom built systems, you had some open source, small, which were sort of floating around and doing their own thing. But custom build was, the large. Whenever you needed an application, you went to an IT services company and said, build it for me. There were some proprietary systems also, but they were not standardized. And the global leaders, they have not been coming into the Indian market because they don't find that the Indian market is standardized, and they're not able to justify the cost that is required to implement any system like that. So that is shifting. And if you look at the right, a level playing field is emerging for all of these players. And we're going to see, very new players also come into the market, and cutting edge technology like Internet of Things, all the FANG, which is Facebook, Apple, Amazon, Netflix, Google. So all of these guys are going to sort of throng the healthcare market. Artificial intelligence is already here in a very big way. And there's going to be a level playing field for the proprietary, custom build, open source. And that's a new world that we are looking at. And it's not conceptual, it is already emerging. The Bazaar model is already emerging. What we are doing is we're working very closely with some of the cloud players like Amazon and others to create infrastructure as a service, platform as a service, and software as a service. At the software as a service, we run a accelerator. We call it the Social Entrepreneurship Accelerator. And there are about 40 plus health tech and med tech startups that work with us. And I talked about, the building blocks that I talked about. So they are implementing all that. And, the time is not far off when the seed that we have created, or, it's a seed crystal. So the crystallization will start around it, and the entire market will crystallize over time. So that's really going to happen. And we see, very clearly see that the retail giants and the telecom giants will play a vital role in making this happen. So we are looking at the endless opportunities to sort of software as a service, taking the healthcare to the masses at the bottom of the pyramid, where the healthcare really hasn't been able to reach in the traditional model. So that's going to happen. I think I will stop at that, and I will welcome any questions that you have. And then, the questions can also be offline, or welcome to sort of put your questions. So thank you so much for listening to me.
Thank you so much. Thank you so much, Dr. Pankaj, for such an insightful session. Well, we do have a couple of questions. I will post it in the chat box, which we will take one by one. And just give me a minute. Here comes the first one. Is open source software HIPAA compliant?
Open source software should be compliant to data privacy and data security standards. Now, HIPAA is a US standard. It is not an India standard. In India, we are in the process of putting together a data privacy, data security standards. Pending that in the parliament, every Ministry of IT as well as Ministry of Health has done some notifications of rules which we should follow. So every open source software should follow that.
Thank you so much. The next one is, can you share more inputs on National Digital Health Blueprint?
So National Digital Health Blueprint was released and notified in November 2019 by the Minister of Health himself. And it is available for download. Anybody can download it. It is giving you a reference architecture for building any digital health application. And any infrastructure that you have to do in digital health. So it gives you a reference architecture for that. And it also refers to standards, the EHR standard and the metadata standards for health. So any building blocks you need. So it also talks about, building blocks for all the interoperability and things like that. So it's a very detailed work that has been done. You're free to download it, and you should be able to implement it. National Digital Health Mission is the body which has been created by government to implement the National Digital Health Blueprint and create a national digital health ecosystem. So there's a full transformation that is underway in India.
Fair point. Thank you so much. Well, Dr. Pankaj, these are the two questions that I have right now. If there are any more questions from the audience, I will direct those questions to you over an email. With this note, thank you so much for taking the time out and sharing your thoughts with us. You stay safe. Take care. I'll be in touch with the next process and progress of the email.
My pleasure. Thank you so much.
Stay safe. Bye-bye.